So I have got a question. What is the difference between pemphigus and pemphigoid? Now, when we say pemphigus, just see here. See, when we talk about pemphigus, pemphigus has the word S in the end, which means superficial. So in pemphigus, what we get is superficial bullous. We get intraepidermal superficial bullous. This is pemphigus. While pemphigoid means deep. We have deep bullae here, which are subepidermal. So pemphigus has intraepidermal superficial bullae. Here the split is within the epidermis. While in pemphigoid, the split is below the epidermis, that is subepidermal. When you look at the image, see the image of the bulla in pemphigus, it's a flaccid bulla. So whenever a question says flaccid bulla, flaccid in Hindi means fuss. So when a question says flaccid bulla, fuss bulla, it is a bulla which is seen in pemphigoid. So the first thing that you have to catch from the question is coming to the differences in pemphigus and pemphigoid, pemphigus has superficial intraepidermal bullae. So whenever there is a question on pemphigus, it is going to say that the patient has flaccid bullae. And whenever there is a question on pemphigoid, it is going to say dense bullae. This is the first thing that you have to catch in the question there. Okay. Now, with pemphigus, we have two types of pemphigus. One do I So when we talk about pemphigus, pemphigus means that there are superficial flaccid bullae. So basically, you don't have to try to understand anything here. With just 3 weeks remaining for your upcoming exam, all that you have to know is how to catch what in the exam. So when an exam question says flaccid bullae, it is pemphigus. When it says dense bullae, it is pemphigoid. When it says flaccid bullae with mucosal involvement, you have to know that they're talking about Pemphigus vulgaris, and when it says only flaccid bullae, no mucosal involvement, this is Pemphigus foliaceus. As simple as that. Okay. So just see the question here. A flaccid bullae with mucosal involvement is Pemphigus vulgaris, and a flaccid bullae without mucosal involvement is Pemphigus foliaceus. That is what you have to catch in the exam. Then clinical signs, 𝗗𝗂 sign, bullous spread sign. Pemphigus. So if a quiz round acantholytic cells are seen on Zank smear, pemphigus. A split in the epidermis, again, pemphigus. Now, this is a question which has been asked in the INI May 23. This is a question that has been asked in NEET 2021. How to differentiate between the two types of pemphigus based on histopathology. So, this is an image of pemphigus. How do you know it's an image of pemphigus? Trace the basement membrane. So, when you trace the basement membrane here, you see that the split is within the epidermis. Now, when you see the split is within the epidermis, you know it is pemphigus. Then you see where in the epidermis the split is. If it is a suprabasal split, this is pemphigus vulgaris. If it is a subcorneal split, you see the split in the upper half of the epidermis, this is pemphigus foliaceus. So this is the thing that you have to catch from the question. Flaccid bullae, pemphigus. With mucosal involvement, vulgaris. Suprabasal split, vulgaris. Flaccid bullae without any mucosa, pemphigus foliaceus. A split in the upper part of epidermis, it is pemphigus foliaceus. Is that understood? This is how you differentiate between the two types of pemphigus. Then we come to pemphigoid. See, in pemphigoid, the first thing that you have to catch in the question is that this is an elderly patient with tense bullae with itching. So in pemphigoid, this is an elderly patient with tense bullae with itching. That in itself will tell you that the patient is suffering from pemphigoid. Okay, that will tell you that this is pemphigoid. Then you look at the image of the histopath. In the histopath, you see that the split is below the epidermis. This is a subepidermal split. And in the DIF, we see a linear IgG deposition in the epidermis, in the subepidermal zone. So the clinical image is different. The histopath, of course, shows the split below the epidermis, and the DIF shows a linear IgG deposition. That is how you differentiate between pemphigus and pemphigoid. Can you tell me a biologic that is used in pemphigus? Can you tell me a biologic that is used in pemphigus? Yes, I'm waiting. Tell me a biologic that is used in pemphigus. Rituximab, that is an anti-CD20 drug, is the biologic that is used in pemphigus. Can you tell me some other uses of rituximab? Where else is rituximab used? Can you tell me any other disease where it is used? Rheumatoid arthritis, lymphomas, SLE. So these are other uses of rituximab. Then amongst the vesicular-bullous disorders, another very important disease is linear IgA disease, which is generally seen in children, called as chronic bullous disease of childhood, where you get the typical string of pearl appearance, and treatment of choice is dapsone. Okay, and a very favorite of all examiners, has been asked multiple times across exams, is dermatitis herpetiformis. The hint that you have to catch in dermatitis herpetiformis is multiple itchy papillovesicular lesions on the extensors. This is associated with celiac disease. In the histopath, we get papillary tip abscesses. See, this is one of the micro abscesses that you see in dermatology, papillary tip abscesses, which are composed of neutrophils. And the DIF shows a granular IgA deposition at the basement membrane zone. So DIF shows a granular IgA at the basement membrane zone. Any other doubts? Now, there is another question. What are the expected questions for NEET PG 2024? See, when you look at the NEET papers from the previous years, there are some questions that are there in every exam. Now, if we write the important questions from every exam, I will tell you the most important topic that you have to know without any doubt is STDs. Genital ulcer or a disease on vaginal discharge has been asked in almost every exam over the last 5 years. Second most important topic are the bacterial infections. In the bacterial infections, a question on follicular pyodermas, like there has been a question on a patient suffering from paronychia in the 2022 paper. Then there are questions on erythrasma. Then you get questions on erysipelas. So amongst the bacterial infections, these are most common. Then you have the subcutaneous mycosis, the simple viral infection. So basically, if I tell you 60% of dermatology that comes in the exam is infections. So STDs, other infections are the most important because they are there across all subjects. If you revise them from any subject, you know you can deal with questions from another. Then we have psoriasis and lichen planus as very, very important points. So psoriasis, lichen planus, and without fail, a question on nutritional deficiencies has been asked over the last so many years. So pellagra, acrodermatitis enteropathica, phrenoderma, these are all extremely important. Okay. These are the topics. If you do them from dermatology, I can tell you that you will definitely be able to do all the questions. Apart from that, HIV and dermatosis is very important. So in HIV, we have Kaposi sarcoma. Then last year they asked histoplasmosis. So similarly, you need to know cryptococcosis also. So these are some other questions that have been asked. Any other things that you want me to discuss? Multiple sclerosis does not really have dermatological manifestations. So don't have any questions from dermatology here that will be covered in medicine. Any other doubts? Acha. Okay, Dr. Santosh, I got it. So you want me to discuss bacterial infections? I'll show you bacterial infections at a glance, the important ones. I would say bacterial infections is an extremely important topic because it is covered in microbiology, it is covered in dermatology, in medicine. So that actually makes it like an omnipresent topic. See, I'll start from here. These are the important bacterial infections. I hope you all are here with me on this. See, I will just be discussing the important points about the images. This is non-bullous impetigo. You see golden yellow honey-colored crusting on the image. An important complication is PSGN. Then we have bullous impetigo, which is caused by Staph aureus. You see these pus-filled bullae. Here you have to know what is the target of the toxin. That is desmoglein 1. What is the level of the split in the epidermis? It is a subcorneal split. Ecthyma, they don't ask you as such. With erysipelas, you need to know the target of infection here. That is dermal lymphatics. The upper dermal lymphatics are involved in erysipelas. And this is a painful lesion with a clear, well-demarcated margin. That is the difference of erysipelas from cellulitis, which is an infection of the fatty tissue where you get a loose, diffuse swelling without any clear margins. Now, we have staphylococcal scalded skin syndrome. We've got a question in NEET 2019 from here. Here, there is a toxin, which is epidermolytic toxin, spreads into the blood, damages desmoglein 1, causes a subcorneal split. Baby presents with generalized peeling all over the skin. Very important to note, there is no mucosal involvement here. So in staphylococcal scalded skin syndrome, patient presents with a generalized peeling of skin all over the body without any mucosal involvement. That is staphylococcal scalded skin syndrome. Then in the follicular pyodermas, you can get a question on a furuncle, Staph aureus, carbuncle, again Staph aureus, multiple contiguous hair follicles, most common site nape of neck, seen in diabetics. So carbuncle is seen in diabetics. Then paronychia, this was a question in the NEET PG 2021. It is a staphylococcal infection of the nail fold. Patient will present with red, pus-filled, painful lesion on the nail fold. And the question that was asked is, a patient suffering from paronychia developed a painful streak on the arm. What is the antibiotic of choice? So if this patient develops this complication, this is lymphangitis, which has developed secondary to paronychia. Treatment of choice here will be an antibiotic that works on Staph aureus, which is amoxiclav. Then erythrasma, without any doubt, extremely important, asked in INI-CET, asked in FMGE exams. Everywhere it is a very common question. Causative organism, Corynebacterium minutissimum. This is a commensal, causes infection mostly when a patient is diabetic, presents with hyperpigmented scaly lesion in the skin folds. Wood's lamp shows a coral red fluorescence. So this is erythrasma. Pseudomonas causes ecthyma gangrenosum. This is different from the ecthyma that is caused by staph and strep. Then we have meningococcemia, patient with fever, neck stiffness, vomiting, and purpuric lesions. That is meningococcemia. Lyme's disease, expanding annular rash, which is erythema chronicum migrans, caused by Borrelia burgdorferi. Vector is the Ixodes tick. Scrub typhus, very, very important for the INI exam, can be asked in the NEET PG exam also. Here, patient presents with a fever, CNS signs, and eschar. This image of eschar is very important. Treatment of choice, doxycycline. Can you tell me some other causes where a patient presents with an eschar? Can you tell me some diseases where a patient presents with eschar? Can you tell me some diseases where the patient presents with eschar? The mnemonic for that is stage. S is for scrub typhus. A is for anthrax. And EG is for ecthyma gangrenosum, which is caused by Pseudomonas. So this question has been asked in the INI-CET over the last 1 year, 2 times, causes of eschar. So you need to know cutaneous anthrax, scrub typhus, ecthyma gangrenosum. These are the 3 most important causes of diseases which present with this thick black adherent crust that is called as eschar. See here, another S is for spider bite. So these are the causes that have been asked. Then TBVC, you know, a single warty lesion here with a rough verrucous surface, that is tuberculosis vericosa cutis. Lupus vulgaris is important. Here patient presents with a fleshy reddish brown plaque which has active margins and scarring in the center. So this was a question asked in the FMG exam in January 2024. Patient presents with an annular lesion with active margins, scarring in the center. This is lupus vulgaris. A finding on 𝗗𝗃 is apple jelly nodules. Scrophaloderma, generally seen in children, multiple discharging sinuses with bluish margins on the neck of the child. This is scrophaloderma. Lichen scrophalosorum, again, grouped papules on the trunk of a child. So this is briefly about the bacterial infections. Any other doubts that you have? Any other doubts? Okay, there is one thing that I want to ask you. What is your approach to genital ulcers? Are you clear on your approach to genital ulcer diseases? What topics are more for concentrating? I just told you sexually transmitted diseases. Very, very important. You get a question on genital ulcer disease. You get a question generally on the vaginal discharges, especially bacterial vaginosis, Amsel's criteria has been asked almost every alternate NEET PG exam, as well as the FMG exam. Then, second most important, psoriasis and lichen planus. Very, very. Then, infections, in which bacterial infections and fungal infections are very, very important. You know, these are two common ones that they will ask you every time. After this, nutritional deficiencies, in which we have pellagra, acrodermatitis enteropathica, phrenoderma. So if you go back and see the questions in every exam, these topics are repeated every year. For the NEET PG exam, HIV dermatosis. They have recently been very fond of asking Kaposi sarcoma, histoplasmosis. So dermatological conditions in HIV is another thing that I will want you to read. Now, coming to genital ulcers, what is your approach? First of all, when we see a patient with genital ulcer, you have to see whether it is a painful ulcer or a painless ulcer. If it is painless, what are the two important causes of painless ulcers? What are the two common causes of painless ulcers and what are the two common causes of painful ulcers? Tell me. See, painless ulcers, we have syphilis and donovanosis. These are very important. Syphilis, the question is going to say, see, these are the keywords that you have to identify in the question. A painless, indurated ulcer with painless lymphadenopathy. With donovanosis, the keyword is a single beefy red painless ulcer. with chancroid, multiple painful ulcers with painful suppurative lymphadenopathy. With herpes, it will be grouped vesicles with painful lymph nodes. So these are the key words that you have to identify in every question. If you can identify these keywords, you will be able to go and solve every question of genital ulcer that is asked. See, syphilis will be a single well-defined, painless, indurated genital ulcer. Next investigation, dark ground microscopy, corkscrew motility. Donovanosis, beefy red ulcer, no lymphadenopathy. You see Donovan bodies, which are close safety pin appearance bacteria that you see in the smear. Chancroid, multiple painful ulcers with painful suppurative lymph node. The finding on the stain is the railroad track appearance or the school of fish appearance. This is chancroid. With herpes, grouped painful vesicles, what you see on the smear are multinucleate giant cells. With another finding, can you tell me another finding that is seen in herpes genitalis apart from MNGs? This has been asked in the INI CT 2021. A second finding which we get in the Zang smear of herpes apart from multinucleate giant cells. Acantholytic cells. So you see these two things. You see multinucleate giant cells. See, you see these multinucleate giant cells. And you see these rounded acantholytic cells also in the smear. So there are two findings here which you have to know. Any other doubts? See, this is the groove sign of green-black that is there in LGV. Patient presents with painful suppurative lymph nodes. There is no genital ulcer. That is why LGV was not written in the, differentials of genital ulcer. I had only written 2 here, 2 there. LGV, patient does not present with genital ulcer. Patient presents only with a painful suppurative lymph node. That's a bubo. And there is groove sign of green-black that is visible in the bubo here. Any other doubts? No doubts? Skin tumors is another topic that is asked often. So there are some tumors which are the important ones, especially BCC that has been asked in the NEET PG 2022. This I would like you to see. See BCC, how do you identify on the image? You see these typical rolled up borders in the lesion. So these are the typical rolled up borders with a shiny surface with telangiectasias. The patient will be an elderly patient, lesion present since 2-3 years. This is a typical basal cell carcinoma. With ulceration, this is called as a rodent ulcer. But again, you can identify the rolled up margins here. And there is another type, which is a pigmented BCC. This will be slightly dark in color, but you can still make out the rolled up borders. Again, the clinical history of an elderly patient with a slow going lesion is what will take you towards a basal cell carcinoma when you come to the exam. Then we have Marjolin ulcer, which is malignancy developing in a burn scar. This is actually a squamous cell carcinoma, which has developed in a burn scar. This is Marjolin ulcer. Malignant melanoma will always be a black cancer. So whenever you see a black skin lesion, you have to think of melanocytes. If it is something which is present since birth, it is a melanocytic nevus. But if it is in an elderly patient, it has the ABCDE findings, that is asymmetrical lesion with uneven borders, multiple colors. That means it is a lesion which is a melanoma. With mycosis fungoides, the question that I ask you is Pottier's abscess, which is intraepidermal lymphocytic collections. So this is an intraepidermal lymphocytic abscess that you see in mycosis fungoides. It is the most common primary lymphoma of the skin. A syndrome that is associated with it is Sézary syndrome, which presents with a triad of erythroderma, generalized lymphadenopathy, and a high count of these malignant cells, which are the Sézary cells in the blood. Then paraneoplastic phenomena, quite important. Acanthosis nigricans association with gastric adenocarcinoma is a very, very, very often repeated topic that you need to know. Acanthosis nigricans with that. See, this is how acanthosis nigricans looks like. Velvety hyperpigmentation on the neck of the patient. Again, this question has been asked 2 years back in the NEET PG exam. Associated with diabetes, obesity, and metabolic syndrome, associated with gastric adenocarcinoma. Now that I have dermatomyositis slide in front of me, I'll tell you Gottron's papules and heliotrope rash, very important pathogenomic findings. Patient presents with bilateral symmetrical proximal myopathy with photosensitivity and skin findings like heliotrope rash and Gottron's papules. With SLE, it will be fever, joint pains with a malar rash. Can you tell me a drug which is generally given for treatment of skin findings in LE? Whether it is acute LE, whether it is common chronic cutaneous LE, what is that one medicine which is used in disorders with photosensitivity? What is that one medicine which is used? I want this reply because this was asked in the NEET PG 2020 also. What is that one medicine that is used in skin in LE? 𝗔𝘀𝗃𝗧. Please remember, hydroxychloroquine is a drug that is used in all photosensitivity disorders, whether it is SLE, whether it is chronic cutaneous LE, dermatomyositis, then even porphyria cutanea tarda. The drug that we use is hydroxychloroquine. This acts as a systemic anti-inflammatory drug, a systemic sunscreen. So basically, you remember it for all disorders with photosensitivity. Then we have pellagra, the triple Ds, niacin deficiency, more common in alcoholics, more common in maize eaters. Acrodermatitis enteropathica, zinc deficiency, autosomal recessive inheritance, presents with diarrhea, alopecia, and dermatitis. Phrenoderma, deficiency of vitamin A, B, E, and K. So A, B, E, K. Patient presents with multiple papules on elbows and knees. These are dry-looking papules on dry-looking skin. also called as toad skin because the skin looks so rough and bumpy. It looks like that of a toad. So these are some important questions. Other than that, any other doubts? What would be the treatment of choice for neutrophilic dermatosis? And can you tell me one test that is positive here? Can you tell me one test that is positive in a pyoderma gangrenosum or Behçet syndrome in which we inject a 1.1 ml saline into the arm of the patient? That's the 𝗏𝗃𝗧 test. So 𝗏𝗃𝗧 tests are positive in neutrophilic dermatosis, especially pyoderma gangrenosum and Behçet's disease, where patient presents with multiple painful aphthae which are recurrent along with uveitis. And the test that is positive here is 𝗏𝗃𝗧 phenomena. Any other doubts? This is cutis marmonata, and these are the 3 vascular lesions. So I guess we can wrap up the session. All the best, my dear students. Any doubts, you can always message us on the app. You can always connect with me on my Instagram handle, Dr. Pallavi Dermatology. Whatever doubts, we at DocTutorials are with you till you clear your exam. And even after that, whenever you need anything, any doubts with respect to any subject, we are there to help you. So whatever doubts, you can connect with me on Instagram. You can connect with us on YouTube, in the comments, in the app, anywhere. So all the best for the exam. I know you all are working hard. You all will do well. Just keep working hard. Don't lose focus. Actually, the last few weeks, the last few months are the most important time for any exam. How much soever you may have read before, but if you don't use these last few weeks properly, all the hard work from the past might go waste. So if you don't want that to happen, you have to use every bit of your effort, every minute that you can give to studying, but studying efficiently. Okay? So just revise, revise, and revise. Don't read anything new now. In the last 3 weeks, 4 weeks, we don't read anything new. We only revise what we have to be able to recall in the exam. Because unless you revise, there is no recall. So revise, revise, revise. That's it. And do at least 2 revisions in these last 4 weeks. Chalo, then we'll wrap up the session. All the best. Whatever doubts, we are always there. You can connect with us at any point.